Welcome back for our next panel discussion on training and development. The NHS has always been a highly skilled environment from frontline to board level. However, given the current level of vacancies, NHS leaders have had to look at alternative ways to fill the gaps, some of which has been possible through multiskilling. This still leaves a void which requires considerable thought and action. On this panel, we'll be discussing and examining how NHS leaders can effectively fill these voids using training and development. What are the challenges leaders face, and how can training and development help? How do leaders budget for the training required for staff and schedule time for staff development? What tools are available? All these questions and more will be answered with my guests today, who are Lucy Hunte, National Programme Manager, Health Education England, Claire Aspden, Apprenticeship Lead at the University of Southampton Hospitals NHS Foundation Trust, and Kusham Nijar, Thames Valley Training Hub's Apprenticeship Lead for NHS Frimley ICB. Don't forget to join in with the conversation by using our Q&A function, which you'll find on the right-hand side of your screens. So, good morning to our panellists. All female. Good morning. How are you all?
Good, thank you.
Good. Lucy, can we start off with you, Lucy? Have you got a distraction there at home?
Yeah, sorry, it's half term, but it's all right now.
Oh, it's half term. It is. I wanted to start off by maybe you just explaining to us the talent for care agenda and kind of in a nutshell what that is, so that we're all familiar with it in the audience.
Thank you. Yeah, so the Talent for Care agenda comprises of several different components, but starting with kind of work experience, volunteering, those pre-employment opportunities, and then progressing into apprenticeships and paid opportunities. So for us, it's really important to have career pathways from level 2 all the way up to level 7. And we were discussing before we went live, we know that maths and English attainment is a real barrier to recruit new people to the NHS, but also for the existing workforce. So it's making sure that we can support, attract new staff into the NHS, but also support the existing staff to develop. So that's part of, the Talent for Care agenda is all part of what we do.
Wow. And what do you mean about maths and English?
So, for most level 3 or above apprenticeship programs, you need to have the equivalent to I think it's a 4 at GCSE now, a C in old school grades. And we know that hundreds of thousands of young people leave school every year without that. But also in the NHS, where we have such a diverse and international workforce, it's evidencing qualifications that may have been gained overseas, and making sure that they can still access and progress. So we do various things in terms of recognising international equivalencies, but it is a huge issue for us, and we really want to just remove as many of those barriers as we can to allow people to progress.
Wow, I didn't realise that. Kusham, let's bring you into our conversation. Morning to you. What have been your main challenges with GP practice engagement?
Yeah, so if we think about the different parts of the NHS system, the way that primary care is set up is that we are a range of small employers. So we don't have large L&D functions that can really, hold the hands of the practices and show them all the range of opportunities that are out there. Having said that, we've got all of the same workforce challenges. Huge issue with recruitment, retention, and so on. And so increasingly we are looking at what we need to do differently with our workforce development, and apprenticeships, and all the things that Lucy mentioned there in terms of the talent for care work. All of those we know significantly can help towards that attraction and retention piece, but small employers, GP practices, they don't really know enough about this agenda. So a main challenge has been to break assumptions, myths, snobbery around apprenticeships. So, when I first started this role 18 months ago, it is my first role in the NHS. And it is brilliant working in this sector. But eyes would start rolling when I start talking about, if I just say the word apprenticeships. And actually, what is it? It's a vocational employment. So it's employment with training, and the beauty of it is that you're upskilling your staff to have the skills that you need directly in the services that you provide. So, as soon as I start mentioning apprenticeships like the physician's associate, enhanced clinical practice, advanced clinical practice, eyes open. And of course, the doctor's degree apprenticeship that we all know is coming up next year. So, you know, I think some of those challenges I am, along with the leaders across the systems that I support, we are championing the agenda. So we are, you know, starting to break those myths. But the other key challenges around just simply understanding the opportunities, you know, 350 roles in the NHS, apprenticeship routes for all of them, but that they are available for any age over 16, and that they are also for your internal workforce as well as external. So, you know, plenty more challenges, of course.
Wow. Well, I'm going to move on to Claire with her apprenticeship lead hat on, because I'm sure Claire's got plenty to say about what you've just said. But gosh, that's interesting, because all those years ago, 103 years ago, when I left school with my A levels, my teachers were horrified that I didn't want to go to university, and I was an apprentice journalist. But in those days, the only option was English literature. Well, that was no good to me as a, you know, I'd already battled through Chaucer and Shakespeare. So I'm a massive fan of apprenticeships. And listening to what Kusham said, Claire, gosh, we've got to get that word out even more, haven't we, about the value and dispel some of these myths.
Yeah, absolutely agree. You know, I on the other hand, I'm the other end of this scale with from Kush, that I've been in the NHS 34 years. So I can say it's safe to say I've got a breadth of knowledge and experience working within the NHS itself. There are, I thought your term, Kush, snobbery is absolutely right. And you know, for me, there's a lot of myths around, you know, particularly degree apprenticeships being equivalent to a degree if you went to university. So for me, it's around that, you know, getting the word out, making sure people are aware that they are equivalent, you know, particularly when there's a professional registration at the end of it. So your physios, your occupational therapists, your operating department practitioners, and your registered nurse, you know, all these professions, via the apprenticeship route, universities have to be accredited in order to deliver those programs. So in essence, all the difference is it's a delivery model that's different. It takes them a little bit longer, but the delivery of the apprenticeship is exactly the same learning as if you were going to university. And the joy, of course, you know, for the candidates is that it enables people who potentially wouldn't have been able to go to university because they have a house, a mortgage, children, you know, life. And, you know, certainly us as an organisation, we've offered 230 employees an opportunity to become registered professionals. And I think, oh, my doorbell. And I think you can never predict those things. So for us, it's a huge retention opportunity. You know, we've retained majority of our registered nurses who've qualified last year. You know, and if they didn't stay in our organisation, they still remained within health. So, you know, it's the greater good for us. You know, we only take for our degree apprentices internally. We don't advertise externally. And yet, you know, we get year on year out, we get at least 80, 90, 100 people applying. So, you know, we know that there's the hunger. We know as an organisation that we need registered professionals, registered nurses particularly, because that's where the gaps are. But, you know, there has to be this myth that, you know, quash the myth about it's not the same. You know, don't diss the fact that these people are still going to be professional registered people at the end of the programme. So that for me, it's about making sure people know that it's the same. There's no difference. And you know, the opportunity, we've had people that have come back to me after 4 years and said, I can't believe where I am now. You know, and these are people who never had hope, who never believed that they were good enough, who, you know, were upset at interviews because they didn't think they were ever going to make it, and yet are now practicing as registered nurses in the workforce. And you know, you can't measure that. You can't measure the joy. And then even this week I had an email from somebody who said that started out was eternally grateful. That was the start of the email. And it's somebody who's done about 6-7 months on the nurse degree apprenticeship, and said, wow, I can't believe I'm loving this. I'm learning so much. Thank you for the opportunity. I would never have had this opportunity, you know, if you hadn't let me, you know, go forward. So I think, you know, that's the good bit. And it applies to all apprenticeships, not just the degree ones. It's where people go.
Yeah, I think it's very cool. I think it's very cool as you get older as well to carry on learning. And apprenticeships don't have to be just done by sort of, you know, youngsters who are leaving school. We we all have an appetite to learn. Lucy, give us a flavour of how apprenticeships are being used in the NHS, but also can you tell us about the recently announced medical doctor apprenticeship that Kush actually just mentioned in her answer briefly?
Yeah, so this is really, really exciting development for us. As Claire just said, it's around widening participation and access. So we really do need to raise the parity of esteem around apprenticeships. There's been an awful lot of negative press recently. My other half even came back to say it was being debated on LBC. And it's just because people don't understand apprenticeships. So for the medical doctor, it's going to be the exact same degree regulated by the GMC, delivered by the same medical schools that do the traditional route, but this just means that young people that could never have afforded to do the traditional route now have that opportunity. So it's going to have the same strict academic requirements. Essentially, doctor's training is 7 years, but this degree will be 5 years where they'll be being paid a salary. So there's some alarming statistics around, I think it's 70% of current consultants have a parent or grandparent that is a consultant. So where is the diversity in that? Where is kind of widening that access route? So this is really exciting. The pilot will be starting in September 24, and we hope to have 200 people. And this will be 200 people that could never have afforded to train via the traditional route, because essentially you're unpaid for 7 years. So unless you've got a family that can support you with living expenses during that time, it's just not achievable. So this is really, really exciting and a huge development. And we really hope that it will raise the parity of esteem, because actually we're going to have young people saying, so wait a minute, I can get a degree, I won't have any student debt, I'll be earning an income, and I'll have a job at the end. You know, it's a no-brainer.
Yeah, it certainly is. Kush, are you excited about it too?
Absolutely, yeah, absolutely. I won't lie. Some of the myth that's being shared out there on the media channels is not being helpful for when I'm having these conversations, because naturally there's curiosity, and partners are, asking about what would the placement process look like, for example. We get into that conversation and then it's, well, if I'm going to employ them, pay them, but then they won't be working with me because they're going to be on placement, they'll qualify and then they'll leave, so there are there are a lot of challenges, I think, along the way. But as the program becomes more clear, I think that we're going to get into some really great conversations. And really, this, for us in primary care, I think this is about having a systems approach to developing our local people. It is exactly about widening participation. And yeah, I think once we get some more answers, once we see what the pilot program delivers, and that the pilot is a really important piece of implementing this work, I think there's so many potential benefits of this route, but we don't know yet because it's new and we haven't done it. So we've got to be patient.
But it was the same with nursing, well, wasn't it, Claire?
Yeah.
We had all of this with
Yeah.
nursing, and now we've got nearly 10,000 registered nurses. So, as Kush says, I think it's just making sure that there's the communication and we just bust all the myths, because anecdotally, we're hearing that the nursing apprentices are head and shoulders above the traditional route. The retention is at almost 97% compared to 30% attrition for traditional route. So, I think that's very telling in itself. If they're completing their programs, then it must be going well. But yeah, the attention's in the detail, and I think we'll have more evidence of that shortly.
And I agree, Lucy. I agree. Our attrition on the nursing program is 3%. So you can't argue with that. And the ones that left for absolute genuine reasons, and they didn't. We try and keep people on program as much as possible, but sometimes it's just not possible. But I think 3%, and that wasn't until the final year. So we made 3 years without anybody leaving program. It was only the final.
I think also you're busting a myth as well. There was a myth that always used to irritate me, that if you did an apprenticeship, you weren't as bright. And that's also absolutely nonsense,
That's incredibly frustrating, because ultimately I believe that if you're studying to do a full-time program, whatever level it might be, and you're working full-time, you need to be academic, otherwise it's just not going to be sustainable. My background is colleges, and even now I've been in this role in the NHS coming up to 8 years. I still get, oh, I didn't know the NHS did apprenticeships. People think it's still the trades like plumbing and hairdressing, which, not devaluing those at all.
Yeah.
But actually now you can be educated up to master's level via an apprenticeship.
Yeah, it's wonderful. I'm just wondering, Kush, how you're encouraging small employers in primary care to get involved with apprenticeships, and how is that going?
it's really about showcasing the good work that's already going on.
Mm-hmm.
So when I joined, I cover the Frimley and the Bob ICB areas. We had a very, very low baseline on apprenticeship take up compared to other regions in the country. So it was really about pulling out, working really hard to find where those examples are, and then showcasing them across, because, you know, it's just kind of trying to create that interest, just like you have in large organizations, like you would between departments, and showcase, you know, that department's doing apprenticeships, why aren't you? It's the same really with GP practices, but it's also about giving them the evidence and the impact that apprenticeships are making. So, you know, 85% retention rate of apprentices who've completed. So these are the people that completed who are still then working a year later. 85% is, you know, really, really high. But also some myths around, you know, young people as well. So I've got some great examples of practices. One practice she's onto her 7th young apprentice, 6 who are still there 4 years later. Came in as business admin, working in nursing roles or management roles. And the one who left, you know, went to work in construction. So this is really about the environment that this person has created for the young people. So it's showcasing, I think, the evidence, the impact, and the fact that people are actually doing these apprenticeships is not something that I'm saying. And I think the other key is that I've looked at who the system influencers are. And I've worked with the leaders and sold, I hope, I've sold apprenticeships to them. I haven't got everybody yet. I've still got a lot of work to do in this, but particularly in Frimley, they are working really well with me, and they are championing the voice, because they are the influencers.
That's really, really nice to hear. Claire, I mean, presumably you have to engage senior management to support apprenticeships. And I suspect, being a bit of a trailblazer, I hear in your field, that you've got some good tactics up your sleeve to get the engagement that you need.
I do try. So I'm a singleton sort of person in an organisation that's quite of like 14,000 staff. So you can imagine it's quite difficult across to everybody. We have got something that was set up about 3-4 years ago, and it was it's called Workplace. It's a social media platform. Looks a bit like Facebook, but actually it's all internal, and it's about information sharing and that. So I use that a lot to get information out there, and because often the hard to reach staff, you know, not necessarily leaders, but, you know, those who potentially might be looking for apprenticeships, don't have time to sit by a computer and look at an email that's come out, you know. So for me, it was, and you can look at it on the phones, that type of stuff when they're on the break. So it was getting that information out there and really making it very clear about what opportunities are out for you know, entry level right up to, as Lucy points out, to master's levels. But also, you know, I engaged with some of our senior leaders around, we broke down the amount of money each care group was putting into the levy, into our trust levy. So I went armed with figures, numbers, to say your division, your care group are putting in, you know, £15,000 a month in towards our apprenticeship levy, and you haven't got an apprentice. You know, would you want to see return on your investment? And actually, I don't think people realised how the levy was generated, and they didn't think that they were paying for it themselves. So for me, that was an eye opener to some people who look at finance and money and think, actually, oh really? I'm paying that sort of money. Where does it come from? Where does it go to? You know, and those questions. So that was a really powerful engagement. And I know it's a bit underhand, slightly maybe, but actually. It worked for some people. And actually, on the back of a meeting where I went to quite early on in my role, where somebody was absolutely never going to have an apprentice, it was never going to work for them, what possibly could they do? I came away and I got 2 out, you know, 2 apprentice posts out of that person. So for me, it was about just starting that conversation, informing people what the options are. And you know, I do information and guidance to staff. We do a lot of career support for staff. And actually, you know, sometimes it's about making sure people understand which way they can go in an NHS career. You know, if they're going down one road thinking this is for me, and then go, actually, no, it's not for me, what opportunities are there to do other things? And we get managers in that same position where, you know, they may have done a professional registration or professional qualification. Now they want to do leadership and management, and actually, where do they go? And some of the other tactics, which was around staff, senior staff who wanted to do the senior leader apprenticeship, which had, and some do still have, the MBA attached as a gifted qualification. We asked them if they were prepared to undertake the senior leader apprenticeships themselves. They had to support another apprentice in their team. So it was kind of a buy one, get one free. And
I like the way you're thinking there.
so you can say, well, you can't, if you're prepared to do it yourself and you're giving yourself, your 6 hours, 20% of the time, then actually you need to support somebody else in your team to do an apprenticeship. And it worked. So I got a double bubble for quite a while with some of our senior leaders by doing apprenticeships.
It's all why collaboration is so important as well, and these events are really important, that you can all share best practice across other areas. Lucy, I'm going to move on to you. There's kind of a comment from Sarah, really, and then a question. Hang on, I've messed up my computer now. Sarah says, if there's an option of doing an apprenticeship to access a medical career, why would anyone follow the traditional route where they exit with significant debt? The average trainee has 10 years of postgraduate training and accrues 50 to 100,000 of debt. I think it's more kind of a statement from Sarah there. But Nicola, Lucy, says, I work in radiology and we need funding to come through for radiographer apprenticeship training. We need to get people started on these courses ASAP and be able to backfill. We also need to guarantee them a job for them at the end of their training, but it's just not happening quick enough. How can we speed the funding process up without having to submit business plans, etc.? Barriers need to be taken down. Lucy, what are your thoughts on that?
Yeah, so I mean, with regard to the statement, yes, there is a huge challenge. The apprenticeship route for the medical doctor is not going to fill the gap. We urgently need doctors and GPs, but if it can help plug at least 200 of those vacancies, then that's a positive thing. But in terms of the radiography, watch this space. So we are waiting for an announcement about some radiography funding for cancer and diagnostics. As a lot of people may know, HEE recently merged with NHS England, so things have been a bit delayed in terms of getting our budgets approved, but we anticipate that there will be some comms going out this month about how trusts can bid for some radiography funding. I think it's going to be £10,000 per person. So watch this space and we'll make sure that we circulate that as soon as it's confirmed.
Fantastic. Kush, Claire touched on the levy there. How is the levy transfer process working in your area?
We do. Sorry, Kirsten, bumped in there. We do transfer levy out. We have a process where, if we are asked by small employers, if they want to do apprenticeships, we tend to make them relevant to our organisation. So as long as we support things like podiatry, although we don't have a podiatry service ourselves, but we support podiatry. We do. We support our local hospice with their development. Plus, we've done some charity transfers to some sort of like it's not a school as such, but it basically links to health and well-being of the local community. So we try to do it community based within our local area of Southampton, because we feel that's the right thing to do. So yes, we do.
And Kush, what about Frimley?
So I'm keen to keep the money local. So Frimley Healthcare Foundation Trust, Berkshire Healthcare, both support us really well. But actually, there is a lot of demand on them from everywhere. And I support obviously Oxfordshire, Buckinghamshire, Berkshire West as well. So what I've done in each region is I've worked with the local LEPs, so Oxlep, for example, who do a fantastic job of engaging with private organisations, public sector organisations in the area, and almost act like a brokerage service for me. So that's been really helpful. But I've also I had existing relationships with local authorities, so I've reached out to them as well. So I have a process now, and we've been supported by something like I wanted my 27 levy transfers now in 18 months. I know that doesn't seem massive in the acute sector world, but it is increasing, and small employers only have to pay 5% of the fees, of course, but when you are going through a huge transition period, that saving can be significant for a small employer. So I work with the trust, and that's brilliant, but where they are employer providers of apprenticeships, it gets difficult. So I've had to widen that net, and it's working really well.
Lucy, just a final thought. How, in a very busy environment, how important is it that leaders schedule and find time for staff development? How do they, it's important. How do you encourage that so that people can just take a step back and see the wood for the trees? Because obviously the NHS is so busy every day, 24/7, you know, how important is that staff development?
It's incredibly important. You know, we know it's been very challenging, certainly during the pandemic, but you know, I think that it is really important just in terms of staff morale and retention to be able to offer them that development. And we do know that there will be unexpected incidents, and you know, when trusts go on lockdown, then obviously things might have to be paused. But it's just really working with senior leaders, apprenticeship leads, and staff to make sure that they can stay on program. There is flexibility, you know, if there is any reason why they need to go on a break in learning or anything like that, then that can be managed. But I think it's prioritising that learning and development, and making sure that we have the skills and the workforce that we need for the future. If we don't prioritise that, then we're going to be in an even bigger mess than we are now.
Thank you so much. Good thought there to end on. Another fantastic conversation. My thanks to our panelists, to Lucy, Kush and Claire, for giving us some great insight. And thank you to you, our audience, for taking part. Now it's time to hear from our event partner, Shannon Dudley, Business Development Manager at Bank Partners, a highly experienced workforce solutions architect in both UK and international healthcare markets. Shannon's area of expertise is helping the NHS to attract, retain and develop staff by creating new recruitment pathways into the NHS and helping current solutions work harder. With workforce leads consistently being asked to do more with less, it's more vital than ever that suppliers can support with integrated 360-degree workforce models which break the boundaries of traditional workforce provision. Bringing seemingly disparate workforce deliverables under one model is key to achieving cost savings without compromising on the welfare of the workforce or the experience of the patients. Sounds simple, but how can this be achieved? Please welcome Shannon.
Hi everyone, and thank you for having me today. Hopefully I can have a little chat with you about what we can be doing to really elevate our workforce solutions across all of our services. If we could just slip to the next slide, please. So when we say supercharging our staff bank, what do we mean by that? Now, we all know how vital flexible workforce solutions are to delivering our services and making sure that we're able to safely deliver patient care. Now, in the past, our flexible solutions, whether internal or outsourced, have definitely been good, and I think we can all celebrate that. They look at, but what they have been is reactive. Looking at a siloed area of our workforce without necessarily establishing root cause analysis for why that demand is needed, or why I think we can all agree that we've seen an increasing trajectory in that demand. When we talk about supercharged staff banks, we mean looking at the root causes of issues that we have in demand and our capability to fill those with proactive data-led solutions that really drive innovative new ways of utilising our vital workforce in the most effective manner we can. If we could go to the next slide, please. So who are we to talk about that? I am here representing Bank Partners, part of the Acacium Group. We have been delivering workforce solutions primarily in staff banks for over 25 years. Just to give you an indication of the level of services that we're delivering, we filled 1.1 million bank shifts in 2022 across a multitude of suppliers in London, Greater London, and across the UK, including the South East, the South West, etc. Primarily, we're doing that within the NHS, but we do also work with the private sector. And we really utilise the level of services that we're providing to get a really wide market understanding and bring those insights into the NHS so that we can make sure our services and the work you're doing is really as effective and efficient as possible. If we could go on to the next slide, please. So what do we mean by limited solutions and good solutions that we've had in the past? As I mentioned previously, our bank services have always been siloed, and that's the same across many flexible staffing solutions, again, whether they're in-house or outsourced across the UK. Workforce has always looked at substantive, permanent, flexible and agencies separately, and bank solutions in the past have particularly focused on contingent workforce with things like recruitment and other aspects of the process, compliance, bookings, being very focused on only flexible workforce, with almost looking at agency as a failing when we need to use that. It has used other aspects of workforce, looking at substantive with things like bank to perm transfers, and there's always been special projects around things like direct engagement and supporting the trusts that we work with compliance of wider workforce, but it hasn't taken wider strategies into account for how we can better manage all of our workforce, especially that of contingent. If we could go to the next slide, please. So as we move into, and I hate this term, but I'm going to use it, the new world of working following the pandemic, we need to look at how we can be maximising the efficiency and the effectiveness whilst also retaining quality and thinking of the well-being of our staff. And looking at wider strategies with quality at the core is going to be really key to that. And that's where we extend the services that we're providing. So when we think about our contingent workforce, rather than pure PSL management that it may have been in the past, how do we engage agencies to reduce cost and remove off framework? How in our special projects do we think about really data-driven, proactive demand solutions so that we can manage surge? Because we all know in the services that we provide, they are not the same day to day, and things do change, whether that be winter pressures or elective recovery or other aspects that we need to consider when we're thinking about how we plan our workforce. And then we also need to look at how we stop siloing our workforces and keeping substantive and flexible separate. So taking a total overview of what our workforce looks like with new recruitment models and shared best practices. And then it's about looking at our root cause. And that comes in always back to patients and how they move through our healthcare services, whether that be through preventative care such as smoking cessation or diabetes prevention programs, or looking at virtual wards so we can keep people out of hospital when they don't need to be there, or looking at diagnostics and discharge so that we can get people out of hospital and back into our communities while still supporting those community services as quickly as possible. If we could go to the next slide, please. Now, that all sounds great, but it can be slightly overwhelming to know where to start with that process. So we've put together 8 questions that we can start looking into, whether locally, in partnership across ICSs, or with providers such as ourselves, to really start delving down into how we can make those changes to start looking at our workforce as a whole. If we could go on to the next slide, please. Now, I'm not going to go through all of these questions in detail because I could be here talking all day. I think one really important thing for me to always consider is data. I'm a scientist by background, so I'll always go by the data. But actually, it's really important that we delve down into what's happened in the past, what's happening and what's happening now, so that we can start to predict and drive change for what we're going to need in the future. And that for me is really key in being more proactive in our services and really aligning what we're doing to both what's needed on the ground and also to our long-term plans of cost saving while retaining that quality. Now, we're always going to have agency use, and we know that it's there, it's not going away, but how can we make sure that we're having zero off framework in all of our services, and that what is being supplied into your services is of high quality, of clear compliance, and importantly as well is reducing that cost wherever possible. And that's where we start looking at that wider workforce and that data, so we can really proactively manage that and reduce the need to go out for that off framework use. If we could go to the next slide, please. Thank you. Some more questions here. I think a really key one for me here is that looking at things like surge capacity is really important with the data I've just mentioned, but really it comes down to knowing our workforces and understanding them, what makes them happy, what their behaviours are, so that we can manage them as effectively as possible. Now, technology is always going to play a part in that, but how are we using technology to really enable an end-to-end service and engagement with our workers, rather than relying on that as the only solution? And how are we working together across all of our teams to really understand what is happening within local silos, but also across our workforce as a whole, whether that be a trust, an ICS, a local authority, or even the UK as a whole, and really understanding what we need to do to retain those vital workers. If we can move to the next slide, please. So, how is the work we're doing helping drive some of those activities? Now, Bank Partners is part of the Acacium Group, which is a global provider of healthcare staffing services and workforce solutions. So we have combined our market insight, our data, and our years of experience to really understand how we can start driving some changes in those root causes that we're seeing for increased demand, reduced retention, and looking at new career pathways into care, so that we can really be expanding our workforces, retaining our workforces, but also utilising them in the best way possible to ensure that we're keeping that patient pathway of the highest quality possible, but also really caring for our staff at the same time. And one way in that we're doing that is in a new staff bank model. Now, that's always going to be bank first, that's never going to change. But what we've done is we've created an additional layer in the way that we fill demand and requirements, and that comes in a tier 0 model. What we've done is we've reduced the number of agencies that supply within that tier 0 model, all of whom have specialist, clear and constant supply and quality of service. They have all committed to a certain level of fill. They are all framework providers, and they all have a high and clear quality pathway with real performance metrics. But the real key here is that they've agreed to do that supply at a reduced rate. So where bank cannot fill all demand, where that isn't possible, we have a group of agencies that will fill that demand at a reduced rate, so we can still keep striving towards a cost reduction whilst ensuring that we're maintaining safe staffing and patient safety with quality at the centre of everything. And then in addition to that, we are working with other brands within our group, such as Xyla and CHS, to really delve down into some of those root causes so we can reduce demand. Things like health checks and prevention to reduce the number of people that are needing to go into hospital, or technical solutions such as virtual wards. So we're keeping some of our most vulnerable people out of hospital where they may not be able to move through the system as quickly as possible. And then also things like discharge services. Not only supporting within the acute sector to discharge through the process, right from even before people walk through the door, but also supporting our community services to make sure that they have capacity and capability to support those patients once they leave a hospital. If we could go on to the next slide, please. So I'm not going to talk through all of these numbers in detail, you can have those in our slides after, but I wanted to show you why we're confident in these kind of models and how we know that these solutions and starting to talk as a total system solution can really make a difference. If we could go on to the next slide, please. And we just have some feedback here from one of the trusts that we're working with in London, where we have delivered a number of different services alongside a very well-established staff bank solution to really start delving into those root causes and that total workforce view. Again, I'm not going to read it out. That's something that you can look into afterwards if you're interested. And if anyone wants to discuss this in more detail, or even talk about how we've come to some of this information with some of the data and the market insights that we have, we'd be more than happy to discuss that moving forwards. So thank you very much for your time. It was lovely to speak to you today. Thank you.
Shannon, thanks very much. Great to hear everything that's happening at Bank. So it is time now for another break. Please take this opportunity to network with your fellow participants by using our speed networking function. And I'll see you at 11:35 for our final session before lunch. Cool. So we have got to 11:30.